We'll move on now to Gianfranco Di Vanna, who's going to round up the evening, giving us some practical advice on how to do this examination successfully. Gianfranco, over to you.
Thank you, Paul. My role today is to give you some tips and recommendations needed to perform a successful contrast examination. So I'm going to share with you some practicalities that you might keep in mind while you're doing contrast ultrasound, independently on your level, either you're a beginner or an expert. Let's talk about the product. So what is the sonoview bubble? Sonoview bubble is a phospholipid shell embracing an inert gas. So the phospholipid shell is elastic, is flexible, and that is going to give the enhancement to the machine. While the gas gives stability in time, and that's why you can scan continuously until 6 to 8 minutes in this case, and that is a good advantage. So machines are tuned for these flexible shell sending waves back. I'll explain more about that in a minute. So what happens when you hit the bubbles with low MI? Bubbles reflect and oscillate. And that is an important feature because that's going to give you what is the performance of the machine is going to be optimized because it can detect the bubbles instead of the tissue. So as Tim said, Sonoview is a blood pool agent. It remains in the vascular space. It doesn't go through these interstitial spaces. So it keeps going on and on until its elimination. The gas gets expelled by the lungs, by the normal breathing, and the phospholipids metabolized in the liver. So in about 15 minutes, everything will be gone from the body. So let's talk about the shaking of the product. There's two times when you need to shake. The leaflet says vigorously shaking. So one is the first time you prepare the product, you will be shaking for 20 seconds to make sure that you mix the lipids and the gas. And then the second instance is every time you need to use the product, it is recommended to shake it again. So what is the shaking doing? It's going to create a whole difference of bubbles. There's a lot of up to 500 million microbubbles per milliliter, where the majority of bubbles will be 2.5 micron. And most importantly, the stability after reconstitution, after the preparation, is 6 hours at room temperature. Sorry, I'm just having some difficulty. There you go. Okay, so 6 hours at room temperature. That means between 15 and 25 degrees. Remember, there's a gas inside here. There's no air. And the only way to combine the phospholipids and then integrate the gas into it is by shaking. So keep that in mind every time. It is also recommended to leave the vial on the table. So you don't keep shaking, don't keep increasing the temperature in the vial, don't keep it in your hands. Because as I said, it's 15, 25 degrees. So remember, it's lipids. So you want to make sure that everything gets stable, as stable as possible. So by heating the bubbles with the wave from the probe, you get what is called the non-linear response. So if you can see that with the MIs, an MI range from 0.1 to 0.3, which is low MI, bubbles will oscillate. And then machine is going to hit the bubbles, and then the bubbles will send back some waveforms. Machines are tuned to identify those waveforms and then select the blood flow against the tissue. That's why when you start the examination, you will see that everything is dark because there's no tissue signal coming back from it. So what about the parameters that are important in contrast ultrasound? MI is important, yes, of course. That's a power. That's a acoustic power sent. The gain as well. The focus position is a stressing point. So in our case, sometimes, most of the times, you need to put the focus below the lesion. The injection rate is also helping because you need to see the arterial, the portal, and late phase, and then the rate will help you on that. A new machine will also help because the sensitivity is much higher. But is that all? There's one more. Don't forget to shake vigorously. That's why I said the leaflet says shake vigorously. That means shaking. The agitation guarantees a homogeneous concentration before the injection. Please remember that when you increase the concentration, then you inject it in the veins, but synovium is not going to be modified because it's the phospholipids and the gas are both hydrophobic. So they will remain in the same state you inject them. So many different bubble sizes, remember I said up to 500 bubbles per milliliter, will be in the bloodstream. And that is crucial for the machines to identify the blood flow against the tissue. So the mixing is crucial for a good and strong enhancement. So let's do some practical exercise here. So you can see the agitation on the left. So you create concentration up to a certain level. Then you put it in the veins, that's the injection, and then it will gradually go down. There's many factors influencing that concentration. The MI is one, the preparation, because you need to prepare it right. You need to have certain millions of bubbles. The administration rate, the way you do it, if you have a needle, thin needle, or if you're doing tubings or long tubings. The elimination rate, the metabolization of the body is also an influence. And then obviously the way you agitate before injecting it. Let's talk about some of the settings. The mechanical index is a transmitted power. So it's going to destroy the bubbles. That will destroy the bubbles. So you need to remain within a certain range. The gain is a receiving amplification. It's not going to destroy the bubbles, but it will allow you to see, as Tim was showing, a much better, and Paul as well, a much better enhancement all along the scanning plane. TGCs are also a good way to optimize the imaging. You can see the TGCs on the lower part are higher than on the superficial parts, and that is a way to do it. Another thing is sometimes, depending on the MI, you will have some difficulties, depending on the liver, depending on some of the characteristics, you will have some difficulties going down to the deeper parts. You can see it on the left that sometimes the MI is not enough. So maybe MI will help you determining if there's a lesion in the lower parts, and obviously the enhancement will be all along in the best way. So MI needs to be adjusted depending on the lesion, depending on the patient. Sometimes you have any difficulties you have on 2D examination will be multiplied in contrast because we're talking low MI. So you need to adapt those as well. You can see that this 0.06 to 0.20 plus up to 0.3. 0.30 is the moment when you will start breaking bubbles. But if it is needed for you to have a diagnosis in the lower part of the liver and you're sacrificing the superficial part of the liver on the bubbles, that's perfectly okay because you will be diagnosing the lower part. Same as the dosage. Sometimes the tendency today is to lower the dosage because there's a lot of studies on that, but it depends on your machine and it depends on the difficulties you might face. So don't risk missing a lesion. And remember that anytime you need it, it can be repeated. The injection can be repeated. So when you have multiple lesions, sometimes you have multiple lesions and you cannot see both lesions in one same plane. In that case, you will need to do double injections and then do one lesion at a time. And on the right-hand side, you can see that, remember that the waveform coming from the probe needs to hit the bubbles in order to have a good enhancement. So if you're putting an angle on the probe, you will not hit all the bubble sizes, and then you will have some problems on that. So keep that in mind as well. Same as the scanning approach. You can plan before the injection. You do some practice on lesion positions, on more than one lesion, how are you going to approach it, the breathing movements, the position of the probe, everything needs, I normally recommend to do some practice before. And then once you're ready, then you ask for the injection, then you start the examination. So at that point, when the machine is ready, sometimes it happens in the practice that you're scanning and then you say, okay, we're going to inject contrast. And then the nurse is shaking and extracting and then leave it in the syringe. Try not to leave it in the syringe because there's no way to remix the sonogy in the syringe. So when the machine is ready, pick up from the table, as I said before, shake for 4 or 5 seconds again in order to increase the concentration, extract only the amount you're going to be injecting and then inject immediately. How? Fast contrast injection and fast saline flush. I normally recommend 2.4 milliliters in 2 seconds, followed by the whatever you decide to do flush in 2-3 seconds as well. So in about 5 to 6 seconds, you have one package of bubbles showing you a strong arterial phase and then differentiating from portal phase. If you do a slow injection or the saline is going to prolong that, then you might be mixing both flows. Whenever you need extra help, Bracco is offering free visits upon request to assist you on product preparation, bubble trainings for you and the team, setting up some optimization. I am doing that job as well with customers, and this is the best way because you can identify subtle differences or some details that you might need to correct. Preparation on the injection side, on everything else. So at the end of this webinar, you will have a survey. So if you can please respond to that. And then if you're interested in an extra visit, then you can leave your name and your hospital, and then you will be contacted by Bracco personnel. I have finished. Thank you.
Thank you very much, Gianfranco. Excellent overview of the do's and don'ts of administering contrast. And I must admit, in the early days, all of those rules were broken when we were trying to start. I've got a couple of questions because I appreciate we're quite a little bit out of time. The first question, Gianfranco, is for you.
Yep.
Why do we have to have higher doses for small parts as opposed to, like, for the testes, as opposed to the liver? Why is it higher, the dose?
Correct. It is a matter of frequencies. I will try to explain it in a very simple way. When you do the shaking of sonogy, you will be creating bubble sizes from 1 to 10 micron. But the bigger bubble sizes would be filtered by the lungs. So you will be remaining with an optimized size difference between 2 and 5 micron. The majority of bubbles, as I said, is 2.5 micron, which will be giving you around 3 to 4 megahertz reflection. Whenever you use a linear probe, which is a higher frequency, you will not see the same bubble sizes as with the liver. And that's why it is recommended to do a double dosage, because you will be compensating for the bubbles that you're not seeing as it would be when you're doing the liver, when you're using the liver probe, which is the resonating frequency of sonoria. I hope I've been clear.
No, that's clear. I mean, it goes it's contrary to what you would imagine, but
Yeah.
it certainly is very important. So if you're starting to do some contrast in thyroid or testes, for instance,
Yes.
always use the full vial dose.
Yeah.
And also pick up on the point that you were saying about there's a race to the bottom of getting the smaller and smaller dose to see whether you can see things with a small dose. There's just no point because you don't want to oversaturate the view, certainly with too high a dose, but you also want the bubbles to last in the liver until you can see washout. So you want to be very careful about that.
Correct.
Now, the question to you, Tim, are there any differences in the patterns that you see of contrast-enhanced imaging of the hemangiomas in the different liver backgrounds or the different types of appearances of hemangiomas?
So on contrast enhanced ultrasound, the hemangioma is a hemangioma. It's the background liver may differ, may look different on B mode, but the the appearance of the hemangioma will be the same. That typical peripheral nodular arterialization, the infilling, all those flash filling hemangiomas, but they remain the same regardless of what the liver looks like in the background.
Yeah. And one of the issues, and I think I see this very often now, is there is no typical echogenic hemangioma anymore, very rarely. They're all atypical. The fatty liver renders them hypoechoic, but the contrast enhanced ultrasound is pathognomonic, and it's pathognomonic within seconds of the injection. And we're going to see this more and more, and you're going to actually be referring these patients on for further imaging. Contrast enhanced ultrasound, pathognomonic, you have to do it because it'll be the commonest lesion you pick up incidentally. And I'm going to just round up one other question, which I'm going to throw open to you as well, Tim. Why don't we follow the NICE guidelines? We seem to follow it for head injuries and we do CT heads 60 a night, but we don't follow it for contrast enhanced ultrasound for focal lesions. Are we hiding something?
I would say it's, one of the things in radiology, I think, is that we get branded as a service specialty sometimes, and the referrals that come in. So I make a very conscious effort every MDT I'm in to put the image of the CT next to the contrast enhanced ultrasound. So this 3 centimeter lesion looks exactly like this 3 centimeter lesion. So it becomes obvious. And once it becomes in the forefront of everyone's minds, once that fear is taken away of, oh, I have to cannulate, and the appreciation of the speed, how much you've helped the pathway comes in, it will have to become day-to-day use. It's cost effective, it's quicker, it's better for the patient.
And I have to agree. I think in the end, it's not going to be the radiologists or the physicians who demand this patient-friendly, safe, repeatable examination. It'll be the patients who will lobby for this. And it's incumbent upon the radiologist to participate in this as well and encourage use. I have rounded up the questions, so I'm going to hand over to Jerome now to round up and close the session and to thank everyone. And I thank all our speakers, myself personally. Jerome.
Yeah, thank you so much, Paul. Let's conclude this webinar. Thank you so much, Paul, Tim, and Gianfranco for your great talks. Thanks to the audience for your great participation as well. As mentioned before, this webinar has been recorded and will be made available online soon. So we shall keep you posted about this. You will have the possibility to see it again. And obviously, as Gianfranco mentioned, we are available to support you whenever you need and when you wish to start using contrast-enhanced ultrasound. Thank you again, and we wish you a very good night. Bye-bye.